Thank you so much for joining today's webinar for the Kentucky SOS program entitled, This is Your Brain on Recovery. We are delighted this morning to have a guest presenter, Dr. Alex Elswick. Dr. Elswick is also a vital member of the Kentucky SOS Advisory Committee. Dr. Elswick is a tireless advocate for people with substance use disorders. He earned a BA from Centre College and a Master's of Science from the University of Kentucky, and has also finished his PhD at UK. Alex's knowledge and expertise with addiction is multifaceted. His professional experience, nonprofit work, and research agenda all focus on long-term recovery. But most importantly, Alex is himself a person in long-term recovery from the chronic disease of addiction. So Kentucky SOS welcomes Dr. Alex Elswick.
Good morning, and thank you for that introduction. Thank you for having me. I'm Dr. Alex Elswick. As you heard, I'm a co-founder of Voices of Hope, which is a recovery community center in Lexington. And I'm also an assistant extension professor for substance use prevention and recovery, which means in addition to doing traditional teaching in the classroom and research in the laboratory, the majority of my job is research translation, which is taking all that Ivy Tower research that never makes it into the hands of practitioners and making sure it gets there so that folks like you who are doing the work on the ground have the information you need to improve the lives of the people we're trying to help. So hopefully we'll get to do some of that here today. I also just want to say thank you all for being here. I recognize more and more the time constraints we're all under, especially you all, the clinicians and providers. And so I'm grateful you chose to spend some time with me. Maybe you're just like me and you're always interested for an opportunity to learn something new. And I hope that's what this is for you today. I actually think the idea for this presentation, I mentioned it tangentially in the last presentation I was giving, that it'd be interesting to talk about your brain on recovery, and Emily or Claire, one, picked up what I was putting down. And so it's a cool way to develop a presentation. So we hear a lot about your brain on drugs. Oftentimes, in fact, the explanation we get is sort of a bastardized explanation of your brain on drugs. Well, today we're going to cover that only a little bit so that we can focus on what's actually happening in your brain on recovery. And as always, I'm going to start by just sharing 2.5 minutes of my experience, just for the benefit of those of you who don't know me, and also because it's an evidence-based stigma reduction strategy. So I'm born and raised in Lexington, Kentucky, to really fortunate circumstances. My dad's a doctor, my mom was an accountant. I went to private schools, had everything that I could have wanted. But there are two risk factors that I suffered from a young age and that I really couldn't modify. And the first is I likely inherited a genetic predisposition for addiction, tons of addiction in my extended family. And secondly, I've struggled with anxiety for most of my life, since adolescence. I've been diagnosed with 3 different anxiety disorders. It's still something I have to manage to this day. And it's really what thrust me into drug use, was trying to find a way to medicate for the way that I felt. And so I'll fast forward. When I was 18 years old, I was prescribed oxycodone when I had wisdom teeth removed, and I got addicted. And over the next 4 years, I went to jail on drug trafficking charges. I went in and out of treatment centers. I went in and out of homeless shelters. And I ended up spending the last bit of my active addiction sleeping under a bridge in Dayton, Ohio. And I really tell you all of that so I can tell you this. I checked into a Salvation Army, which is really a homeless shelter there in Dayton. And I got to tell you all that the first 60 days that I spent at the Salvation Army are the worst 60 days of my whole entire life. I've never experienced just abject misery like those first 60 days. And I didn't really understand why. I sort of thought that spiritually I was being punished for my drug use. And what I've come to understand now is that neurochemically I was being punished for my drug use. These were the neurochemical consequences of chronic exposure to drugs. And there are so many things that I know now that I wish I had known then, that I think would have dramatically changed my outlook, my hopefulness, and my experience in recovery. And it's really those things that I want to get to share with you today. So to close up this part of the story, the last time I found it necessary to use dope was September 13th of 2013, So it's been a good little while. And, I'm grateful for every day. I learn more and more every day, the things that I need to do to manage my SUD, just like I manage my chronic anxiety. And my life is getting better. So you've probably seen this before. When I give these presentations in person, I like to ask for folks to raise their hands so I can drop this bomb on them. That's not actually your brain on drugs. That's an egg in a frying pan. For the life of me, I haven't a clue what it has to do with your brain on drugs, part of a really ineffective anti-drug PSA, right? So we are going to talk about your brain on drugs because it's important in order to understand your brain on recovery. And so this might be a little bit feel infantilizing, maybe a little bit, but I do this with my students. So if you're willing, do this with me as well. Stick your hand out in front of you like this and tuck your thumb into your palm and then wrap your 4 fingers around your thumb. You've got a brain there, okay? That's your brain. You can put your brains down. All right. If you talk to an evolutionary neuroscientist, so someone who studies how the human brain has changed throughout human evolution, they'll tell you that our brains have evolved inside out. In other words, your 4 fingers there represent the cortices, which is the most highly evolved and most recently evolved parts of our brain. But if you peel back the layers of the cortices and you go more towards the middle of the brain, now we're moving back through human evolution to more distantly evolved structures that we share with other species. That's why we have the reptilian brain, et cetera, et cetera. And we get to a part of the brain deep in the middle of the brain called the limbic system. And it's also called our survival circuitry because it's one of the most important circuits in our brain to enable our survival. And it is so unbelievably critical to understand the limbic system in order to understand addiction and recovery. So the way that the system works is anytime you engage in any behavior that confers evolutionary benefit, which means anytime you do anything that makes it more likely that you're going to survive to live another day, that behavior is rewarded in this part of your brain through the release of the neurotransmitter dopamine, right? The feel-good neurotransmitter. So you drink water, you get some dopamine, you eat food, you get a little more dopamine, you have sex, you bond with a human being, you get dopamine. I liken it to potty training a dog. So I got a Cavapoo puppy in the middle of the pandemic when my mental health was sliding. And, when his name's Buddy, and when Buddy goes to the bathroom outside, we make noise, we click the clicker, we give him a treat, right? What are we doing? We're conditioning him. We're reinforcing that behavior. And in many ways, it's like our brains potty train us for survival. And they're like, oh, you had a bite of a banana? That's a good boy. Here's a dopamine treat, And it's a way to kind of shape behavior. And it's a really elegant system that we have in our brain. And it's a nightmare when it comes to addiction. And so to explain this, just kind of briefly, I'm going to explain it a few different ways. And I realize that putting words on a screen is a really impoverished way to describe this. So don't panic if you don't understand yet. We're going to kind of work through this. So first of all, I'm going to use myself as an example. When I was 18 years old, I got exposed to a substance, opioids, and I experienced an unnatural positive reward. So DA there represents dopamine, huge dopaminergic response. And a couple of interesting things to point out already. The first is I got an unnatural reward. And what I mean by that is there's no behavior that I can engage in the natural world that's going to precipitate the same dopaminergic response. So it doesn't matter if I eat a bunch of bananas or drink a gallon of water or make a bunch of friends, it can't compete, right? But secondly, and I think also importantly, research shows that there's a particular allele, a particular genetic variation that's associated with reduced D2 dopamine receptor density. And in effect, what that means in layman's terms, this is something that predisposes people for anxiety, depression, bipolar disorder, in addition to substance use disorders, right? And so what that means sort of in practical terms is we might be sitting in a circle, we might all be smoking the same joint, but we're not all going to experience it the same way. People who have those those risk factors are going to experience much more of a dopaminergic response, which in turn is a greater risk factor for addiction. Okay, so we use the drug, we experience a positive reward. We're obviously inclined to repeat the behavior in simple terms because it felt good, but that's not addiction. That's just drug use. Where addiction sets in is that our brains and our bodies are always trending towards homeostasis. And so even though you might think that our brains like these huge spikes in pleasure from the drug use, it's much too volatile of an environment for our brains. Our brains like stability, like homeostasis. So it's like what your brain does is compensate all by itself. And it says, okay, Alex, I get what we're doing here. We're taking this brown powder that's giving us this exogenous blast of dopamine, and it's overwhelming my brain. So what I'm going to do as your brain is I'm going to stop producing as much dopamine endogenously, naturally, so that when you use that drug, instead of bringing you way out of control, it's going to bring you into balance. And the net result is less dopamine. And when we say less dopamine, that's kind of a little bit of a misnomer. Really what we mean is fewer dopamine receptors and less dopamine receptor density when we talk about less dopamine activity. And this is effectively what causes tolerance, you know, the requirement to take more of the drug to achieve the desired effect. Okay, so here's my graph for thinking about dopamine downregulation. It's on an arbitrary scale of 0 to 10. 5 is the middle, 0 means none, 10 means the most. And we wake up at a 5. That's our baseline in terms of dopamine activity. And I got exposed to an opioid at 18 years old, and I got an unnatural dopamine reward. Nothing in my life can compete with what I experienced there, or nothing had before it. But eventually, depending on the half-life of the drug, the effects of the drug wear off and I return to baseline, right? Well, now I'm inclined to repeat the behavior. It felt good in simple terms. I use again, I feel great, but eventually the effects of the drug wear off, I return to baseline. Again, that's drug use. That's not addiction. That's dopamine activity in terms of drug use. That's what we might expect to see if most of you were to use a drug. However, remember that our brains don't like all those spikes. They don't like all that volatility. So the brain compensates by itself. It habituates to the introduction of the opioid, such that now when I use the drug, I still feel really, really good. But as dopamine downregulates, I don't feel quite as good as I used to. So when you talk to people who have lived experience in addiction and they talk about chasing the dragon or chasing the first high, it's funny to me because when I read about it in academic literature, it's always written about as if it's some sort of psychological phenomenon, like it's just a craving and it's just something we're making up in our head, but it's not. That's what this research shows that I think is so cool. It's actually a neurochemical phenomenon. It's quite literally the bait and switch that prevents us from recapturing that first experience. And just as importantly as dopamine downregulates, now when the drug is no longer on board, I don't just come back down to baseline, I come down below baseline, or maybe I have a new lowered baseline. And it's important to point out that at this point, we're probably talking about someone who isn't experiencing significant psychosocial consequences from their drug use. So probably haven't lost a marriage, probably haven't lost a job or experienced legals, and yet and still, even at this early stage of their drug use or of their addiction, when they don't have a drug on board, they're a little bit irritable, they're a little bit anxious, they're a little bit depressed, they find it a little bit more difficult to derive pleasure from the world around them. Now they've got two motivations to use again. Not only does it feel good, but they don't want to feel bad. And so it's sort of this self-reinforcing cycle, using and coming down and using and coming down. And the entire time, dopamine levels are trending downward until we reach a stage, in-stage addiction, where a person has to use a drug to feel the way they used to feel when they woke up in the morning, right? Used to, I woke up at a 5, but now I got to use a drug to get there. It's what we consider like a functioning addiction, right? And now at end-stage addiction, when a person is abstinent either by choice or through coercion, through the court system or treatment or whatever it is, it's abject misery. Abject misery. And what I want us to focus on is what's happening in the brain. I'll mention a word on physical withdrawals really briefly, but really our focus here is what's happening in the brain. So these are cool. These are PET scans, positron emission tomographies. Basically what we've done is inject this radioactive substance into a person's brain that has a really high affinity for dopamine receptors, in particular the D2 dopamine receptor site in the brain. And in effect, that allows us to illuminate and take a picture of dopamine activity. Okay, so the brain on the left is a control, a healthy non-drug user's brain. And you can see there's plenty of dopamine available in that brain. The brain on the right is someone who's this is characterized as cocaine abuse. We could, either way, chronic exposure to cocaine, maybe addicted to cocaine, however you like. And there's a demonstrable difference between these two brains, right? Much less dopamine receptor availability in the brain on the right. And what I want us to do is just take a second to unpack the practical consequences of how these two brains might experience the world around them differently. And these are, sort of oversimplified because we know there are lots of other neurotransmitters at play, but I say this just to make the point about dopamine. So let's say there's, Raising Cane's chicken sitting on the counter, and the brain on the left, that person has enough dopamine in their brain to motivate them to eat the food. They also have enough dopamine in their brain to reward them for having eaten the food. And as a consequence, that's what they do. They're motivated to act, they eat the food. A healthy brain responding to stimuli. The brain on the right, the person who's addicted, sees the same stimulus, the same food sitting on the counter, but they don't have sufficient dopamine to motivate behavior. And even if they did, they wouldn't have sufficient dopamine to reward that behavior, to reinforce it. And as a consequence, think about your stereotype of someone who's addicted. What do they look like? They're gaunt and malnourished. Well, of course they are, because food is no longer a sufficient stimulus to a brain that's experienced this dopamine downregulation, right? It's really, really interesting to think about. So we see this in all drugs of abuse: coke, meth, heroin, alcohol, tobacco, cannabis. The only drugs that don't act on the reward pathway are psychedelics. So psilocybin, mushrooms, or LSD, acid, don't really act on the reward pathway, which is why they're thought not to have addictive potential. Another PET scan for you, but this is a little different. In this case, the control is not someone who doesn't use drugs, but in this case, the control on the left is a person whose body mass index registers as normal. And the person on the right is a person whose BMI registers as obese. And what you notice is a very similar phenomenon has taken place here, as we saw in the case of the cocaine user. It's not as pronounced as in the case of cocaine, right? But we wouldn't expect that. Cocaine versus carbohydrates, maybe, right? But something similar is happening here. And it's part of the reason that I show this is because it's interesting to think about the connection between dopamine, overeating, addiction, any behavior, gambling, sex, any of the behaviors that act on the reward pathway. Okay, we don't need to talk too much about withdrawal. I'm sure you all know that the physical symptoms of withdrawal are the opposite of the effect of the drug. So if you're taking a CNS depressant, you're going to experience an elevation in heart rate, BP, all that stuff. Really, the reason I put this on the screen is for the very last word, which is listed as a sort of a footnote of withdrawal symptoms. And I think that's a mistake, because I think it's the most significant thing that we don't talk enough about, and it's going to be the subject of the rest of our presentation today, and that is anhedonia. Anhedonia. So if we break down the constituent parts of this word, an means not, hedonia means pleasure, so it means no pleasure. It's referring to a brain that is unable to experience pleasure. And if I were to say to you, have you good folks ever seen a brain in anhedonia? You'd have to say, why, yes, we have, because that is exactly what you're looking at on the right. When a person has experienced dopamine downregulation to this extent, where they're sort of bereft of dopamine activity just about, we call that anhedonia. That's a person who's not gonna respond to the world around them the same as the brain on the left. The brain is compromised, right? And so, I was always able to make it through withdrawals. That's the funny thing. We talk a lot about withdrawal symptoms, and it is awful to experience, but they're finite, right? They last 3, 4, 5 days. I know that I can get through that. The reason that I relapsed every time I relapsed, and I mean 10 or 15 or 20 times after serious quit attempts, was because of the post-acute withdrawal syndrome and the symptoms that came next. And really, pause is just a fancy way of characterizing the protracted, prolonged, long-term effects of dopamine downregulation. Because it might take you a 10-year drug-using career to get to a place where you're experiencing anhedonia, but it's going to take even longer in order for the brain to repair in some sense. That's why early recovery is so miserable. That's why my first 2 months at the Salvation Army were so miserable. That's why I felt so hopeless. And even when people said things to me like, it gets better, I didn't believe them. They didn't have science to back it. But I wish somebody had told me that the brain science shows my brain will heal. And here's the proof. This is the hopeful slide. So the brain on the far left, we're still looking at a PET scan. In this case, these are methamphetamine users. The brain on the far left is the healthy control, non-drug user. The brain in the middle looks identical to the addicted brain that I showed you before, but here's the catch. That brain in the middle is not actually an addicted brain. That's actually the brain of someone who was addicted to meth, and now they're 30 days abstinent. So for sake of argument, we can imagine someone who's just left a month in county jail or 30-day treatment center, and take a look at that brain. For all intents and purposes, that's an addicted brain. Not only does it look like an addicted brain, but it will function like an addicted brain because it's compromised like an addicted brain. For all intents and purposes, it is an addicted brain. Never mind the fact that that individual hasn't used a drug in 30 days. Doesn't matter. This is the prolonged effect of dopamine downregulation. And this is why it's so scary to treat the chronic disease of addiction on an acute basis, the way we try. Here's the hopeful part. Look at the brain on the far right. This is someone who was addicted to methamphetamine, and now they're 2 years abstinent. And what you notice is that brain much more nearly approximates the healthy control brain, and yet it isn't fully healed. So just pause for a moment to consider that. Here's some evidence that 2 years of complete abstinence, of doing all the hard work, of going to the meetings and talking to the sponsor or taking your medication or seeing your provider or whatever your recovery looks like, doing it right day by day, and you still don't get to experience all the rewards because still your brain isn't fully healed. This is a really important point. And so I want to make this point in a little bit of a different way by thinking about monkeys in a cage. So this is from Lamb and colleagues in 2016. They put 3 monkeys in a cage and they gave the monkeys 2 levers. When the monkey would manipulate the first lever, it would get a little food pellet. And when the monkeys would manipulate the second lever, it would get a hit of rimifentanil, which is a derivative of the fentanyl that we've read so much about. Okay, so you can see on the x-axis is a time delay, which means how long did it take from the time that the monkey pulled the lever before the food pellet dropped? So a 0-second time delay would mean immediately upon pulling the lever, the food pellet dropped. A 240-second time delay would mean upon pulling the lever, it took 4 minutes for the pellet to drop, okay? And then graphed on the vertical y-axis are the number of times that the monkeys chose to use the drug instead of waiting for the food reward, okay? So I'm gonna walk you through this just to help make sense of it a little bit. So with a 0-second time delay, what you see is when the monkey would pull the lever, they would get the food pellet reward immediately. And when that happened, they were largely unlikely to be interested in the drug. Now, there's some individual variability between the monkeys, which is kind of interesting, that one monkey chose the drug at a higher clip than the other monkeys, regardless of condition. But either way, when there was a 0-second time delay, the monkeys really didn't have an appetite for the drug. But what you notice is when the researchers implement a time delay, that is, the monkey pulls the lever and it takes 30 seconds, 1 minute, 2 minutes, 4 minutes to get the food pellet, they become exhausted with waiting. They tire of waiting for the reward and they say, you know what, forget it. I'm gonna use the drug. And I think this is a really interesting, animal laboratory study analogy for thinking about my friends early in recovery. I think about my friends who have experienced dopamine downregulation. They're experiencing anhedonia. They're really, really miserable. And I mean uniquely miserable in a way that I think most people can't appreciate. Their brain is hijacked, it's turned against them. The only thing it wants is a drug. And that's the thing my friends are denying it every day, doing that hard work. And they're doing the things they've been told to do. So just like the monkey was told to pull the lever for the food pellet, my friends have been told, go to your meetings, talk to your sponsor, take your medication, talk to your provider, all those things, right? They're doing everything they're supposed to do. But because their brains take so long to heal, they're not experiencing the reward. And just like the monkeys, if it takes too long to experience the rewards of recovery, you're going to become exhausted and say, screw it, I'll use the drug, right? And so one of the critical questions is like, look, if essentially what addiction is in the brain can be sort of summarized as a problem of dopamine downregulation, then recovery in the brain can sort of be summarized as dopamine upregulation. That's the goal. And so the good news is it happens naturally. If you remain abstinent, your brain will begin upregulating by itself, but it takes a long time. And as I just showed you, the longer it takes for your brain to upregulate dopamine, the more likely you are going to be to relapse. So what that says to me, at least, is we have a vested interest as providers in expediting the upregulation of dopamine, in helping to heal addicted brains. And so what I wanted to offer you all is a few evidence-based strategies for doing that. And I think I urge this at the end in closing, but I also want to urge you to consider communicating this to your patients who have substance use disorder or who use drugs. I'm only speaking for myself. Maybe this is just this patient's perspective, but from where I sit, when I understood some of the science, when I understood that it gets better is not just a platitude, that it's actually a neurochemical reality, I felt more invested in my treatment and recovery. Okay, so first of all, exercise. This one's low-hanging fruit. I assume anyone who works in healthcare or public health, this one's a gimme. But one study from Robertson and colleagues in 2016 found that exercise led to greater increases in D2, dopamine receptor density, than educational groups alone among methamphetamine users. So here we have a really simple intervention. I can tell you, I spent a lot of time in treatment centers just sitting, doing workbooks, having groups, and that's not a knock. Those are legitimate interventions, but maybe there's also room for incorporating exercise, not just for people to experience the acute benefits, the endorphins and the high and whatever, and of course the cardiac benefits and all that, the health benefits, but also the chronic benefits to their brain, because exercise is organic medicine. It makes me so sad when my friends early in recovery, they're replacing drugs with food, they're beginning to gain weight, they're moving less. And what I know is not only is that affecting their image, the way they feel about themselves, but more importantly, it's slowing down the healing of their brain. As they stuff their face with carbs, they're slowing down the healing of the brain. And that makes me sad, because as a person who has experienced upregulation and experienced what it's like to heal, I want other people to experience that. Meditation is another one. One study found meditation corresponded with a massive 65% increase in dopamine activity. And there's that's a dated study. I could have done better for you on that citation. There's a ton of research on meditation in the brain. Another interesting finding is that meditation reduces the density of the amygdala, which is the fear center of your brain. So in a very direct way, it helps to limit anxiety and fear responses, which is pretty cool. Sunlight, greater D2 dopamine receptor availability was found among individuals who had greater sunlight exposure, maybe something all of us can relate with a little bit, since we've had some gray, snowy days. Nutrition, this is a big one. I've actually been working with a lot of our folks in dietetics and extension to build a nutrition curriculum for treatment centers. Because the thing that I saw most often early in recovery when I would go to support groups and meetings was, of course, people using tobacco and nicotine of all different types. Certainly the rate of tobacco use is much higher among people with SUD, but also just people stuffing their face with carbs and like coffee, lots of caffeine, lots of energy drinks, right? I mean, it's such a transparent attempt to try to activate that dopamine reward pathway, and to do it in such a way that's likely going to compromise your brain's recovery. And so I was just doing some preliminary searching on the connection between addiction and dopamine and nutrition. And I found there's a special issue early in 2022 in a journal called Neurobiology and Neurologic Disease on dopamine and nutrition, which I just thought I would suggest to you all. Isn't it interesting that this is now we're beginning to understand the connection. Now we're beginning to see opportunities to really meaningfully help people recover their brain health. And then the last one I put on here, maybe the most important in my mind, social interaction. And probably if you've heard any of my presentations, you've heard me harp on this in one way or another. The more I read the literature around this, the more I believe in the importance of connection and social interaction. So this is just one paper that was published in Frontiers in Behavioral Neuroscience in 2010. And the title says it all: the rewarding nature of social interactions. And what the paper goes on to suggest is that social interaction, pro-social activity, upregulates dopamine. So in many ways, social interaction is organic medicine to the addicted brain. And that's a beautiful thing to say and to think about, but when you really consider the reality, if you were to try to design a society whose entire goal was to disenfranchise, to ostracize, and to disconnect people who use drugs, you would design our society today. We continue to pass laws that do exactly that push people farther away, that disconnect them even more, which is going to have a dramatic impact on the recovery of their brain health. So I'll give you just one quick thought experiment to think about the relationship between dopamine, social interaction, and in a minute, what I'll explain are attractive alternatives. So I first read about this in Gabor Mate's book, In the Realm of Hungry Ghosts. So that's why I cited him here. But the rat park studies really come from Bruce Alexander. So in the 70s, well, first in the 50s, researchers had done these studies where they put rats in a cage and they gave them two sources of water, just water and water laced with morphine. And over again, the rats would use the water laced with morphine, and they would use it to just the utter neglect of their basic needs. Stop eating food, stop mating, stop bonding, and they would die. And so the researchers concluded this is our model for addiction, right? If someone gets exposed to an addictive drug, they're going to use it more and more until they die. And that was fine. But when Dr. Alexander came along with his colleagues, he said, that's not an accurate reflection of the way that people use drugs in the real world, because people don't live in cages absent attractive alternatives to drugs. And so what he did was he created Rat Park, which you see on the left side of your screen, just like heaven for rats, great place to live, all these, symbiotic rat relationships going on in the rat village, and hamster wheels to exercise on, and thriving rat community. And then they replicate the study. They introduce the same two sources of water, but in Rat Park, the results are completely different. Vast majority of the rats don't like the water laced with morphine, and those who do use it in moderation. None of the rats in Rat Park die. And this study has been interpreted to a variety of different inclusions, but I think the one that is most important is about social interaction, versus isolation, and about attractive alternatives. That when the rats were in a community where they could interact with each other, where the rats could exercise, where the rats could do all these other things, when they had something better to do than do drugs, then all of a sudden it seemed like a good idea to do something other than doing drugs, right? It seems a little oversimplified, but it's pretty important study. And so a lot of folks criticized it and said, fine for rats, but how do we make the same assertion? How do we generalize that to human beings? And interestingly enough, Vietnam provided sort of a naturalistic experiment. And Lee Robbins did a ton of this work. So when the soldiers were in Vietnam fighting in these horrific conditions, Robbins found in their data that 30% of US military in Vietnam were heroin users, 20% met the criteria for addiction. And yet, when they returned home after the war and they left that horrible environment and they came back to loving families and thriving environments and meaningful reciprocal social obligations, less than 1% remained addicted. And that totally belies the story we tend to tell about addiction in the brain, and addiction is this compulsive, only progressive chronic disease. The reality is social interaction matters. Attractive alternatives matter. These are things that really make a difference. And so when you think about how harmful it would be to pass laws that disenfranchise people, to pass laws that disconnect people, given that the body of the literature is screaming out to us, we need to connect people, and we need to connect them in every way possible. And so that's what we do at Voices. I really am only going to spend 1 minute here, but I just thought this slide did a good job of showing, if you walked into our community center, either on Old Vine or on Limestone or Broadway rather, you wouldn't see people, you wouldn't come in and see people talking about drugs. You wouldn't come in and hear people talking about drug use histories or any of the things you might expect happening in a center where people are recovering from their drug addictions. What people are doing in our center is just connecting. And sometimes they're connecting through an actual recovery coaching session where they're working on their housing or their transportation or getting connected with a provider. But most often, they're connecting in a much more pedestrian way. They're connecting through a book club, through yoga or Tai Chi or meditation or a sober social event, right? Because when someone else walks in, what they see is a bunch of people hanging out. And what I see when I walk in is a bunch of people who are actively healing their brains. They're doing the work to heal their brains by being engaged in social interactions together. So to kind of wrap up, here are my 3 key takeaways for you. The first is to keep anhedonia in the forefront of your minds when you're working with people with substance use disorders or people who use drugs. It's really difficult for me to convey what that experience is like, to really be unable to to experience pleasure, and to know that there's only one thing that'll bring me pleasure, and it happens to be the one thing that I'm not supposed to have. It's hard, it's hard. And so remember that when we're experiencing anhedonia, we're at our neurochemical worst. And I know that that's largely true with patients you see. Oftentimes you're seeing people when they're not at their best, but it's especially and particularly true of people with substance use disorders. What you can't see on their faces and on their bodies is the pain that they're experiencing as a result of anhedonia. And I promise you it's painful. And sometimes that pain comes out of us sideways, And consider the ways that anhedonia might impact outlook, hopefulness, and an individual's perception of their prognosis. I put this in there really just based on my own experience. As I think I mentioned earlier, I really wish somebody would have communicated some of these concepts to me. I really have a sincere belief that if I understood that the science says it's the natural course for things to get better, if I'll just hold off, if I can just abstain, if I can just hang in there a little longer, then it doesn't sound like the platitude, it just gets better, Don't give up 5 minutes before the miracle. Those are all true, but they're not as communicative, they're not as clear, right? Second, dopamine upregulation is your brain on recovery. Figured if we're going to talk about your brain on recovery, that ought to be one of the takeaways, and that's what it is. It's obviously reductive and oversimplified to say that addiction is nothing more than dopamine downregulation and recovery is nothing more than upregulation. But given the amount of attention and time we spend to your brain on drugs, doesn't it make sense to spend some time thinking about your brain on recovery and the ways that we can expedite or optimize upregulation of dopamine? Really encourage our patients to do those things. Exercise, meditation, doesn't matter what it is. The organic medicine of connection, connecting in every way possible. And lastly, the way that I interpret the brain science in addiction is hopeful. Ultimately, it's hopeful to me. When I look at the PET scans and I see that ultimately my brain is going to recover if I just hang in there, that's hopeful to me. And so I think it can be really important to help patients understand that it's not a platitude, that this is what the science says. The science says it's going to get better and your experience is going to get better. It's actually going to feel better. Your world's going to be better. Your burdens are going to be a little bit lighter. They're still going to be there, but they're going to be a little bit lighter, And then just a word on attractive alternatives. Recovery is a whole lot easier when it feels good. It's a whole lot easier when you've got a good life to recover into. It's a whole lot harder when you recover and you look around and everything's bad. So every opportunity we have to connect people, we take those opportunities. So that's what I've got for you today. I'm happy to take any questions that you might have about, I can speak a little bit about the research. I can certainly share about my own experience, whatever you like.
Thank you so much, Dr. Ellswick. This is Emily Henderson again, and we'll open up the lines. If anyone has questions, feel free to unmute your phone and you can ask over the phone lines or utilize the chat box. It looks like we have a couple. We have several great information, and I want to ditto that. I feel like this is a wonderful way that we can encourage our patients in recovery and loved ones, neighbors, family members. This was just wonderful information today and a great perspective. Thank you so much. Are there questions for Dr. Alex Ellswick at this time, please? This is a great opportunity for you when you're treating your patients in recovery. We can get his perspective. So there are questions in the chat box about recording. Yes, this recorded along with all other Kentucky SOS webinars is recorded, and this will be posted on the Kentucky SOS website. And then I will send it out to all the project leads also. In case you missed it, please feel free to share this with colleagues. Feel free to share it with family members and neighbors too, if you know others in recovery. There are questions in the chat box, Dr. Ellswick, if you want to address those.
Excuse me. Yes. let's see. Deb asked, Alex, if I missed it, I apologize. Is there a time frame that can be shared for how long anhedonia lasts generally? And Deb, that is such a good question because I fully intended to include a slide to that effect. So, you know, the one of the slides I did show you gave you the sense that after 2 years, in the case of methamphetamine, and it's largely the same across different drugs, after 2 years, there was partial recovery, right, in the brain in terms of dopamine upregulation, but not full recovery. But when you lay the PET scans up against just sort of the data on recovery rates, what you see is it seems to be somewhere between 3 and 5 years where people experience like a full healing such that their brain isn't compromised anymore. And that's reflected in the fact that after 5 years of continuous abstinence, a person's risk of relapse falls below 15%. And just quickly, the reason why that's a significant value is because that's actually the risk of addiction in the general population. So when a person's risk of relapse is as low or lower than anybody else becoming addicted, then we would call that full recovery. So it's a great question. And then Joan asked, so we often hear, you know, I just can't get out of bed, or how do you think I can exercise? Or I'm just not ready to talk to people. And how can we encourage those social interactions early? That's a really, really good question because we're telling people they need to go do these things, but in order to go do them, it requires the dopamine to motivate you to do it. So we have a catch-22. How are we going to get them to go do these things to build the dopamine when they don't have the dopamine to motivate it in the first place, right? And this is actually a quandary that we face in clinical work. I didn't end up getting my license. I went on to get my doctorate instead, but I was a couple and family therapist in training for 2 years. And when I would see clients who had major depressive disorders, oftentimes what we would have to do is called behavior activation. And behavior activation is really just a fancy way of saying, let's get up and do something. And it's so hard. And it's, you know, it can be frustrating dealing with clients who are struggling with motivation, but it's helpful again to keep anhedonia in your mind. Because if you remember, the reward pathway is responsible for motivating behavior. So when you look at your patients or your clients and you say, wow, they're just so demotivated in their recovery. Well, of course they are, right? Their brain is in such a state that they're demotivated. So I would just keep that in mind also. But yeah, the behavior activation, small steps, that would be my best answer, is small steps. So, you know, we're not going to put somebody on a bodybuilding program today, but man, if we could get them to take a half a mile walk around the neighborhood and maybe do it with a friend, they're going to get social interaction. They're going to get sunshine. They're going to get exercise. Without knowing it, they're making their recovery a little bit easier. And so it's hard to get people invested in those things, I know, and in that actual behavior change, but a good way to do it. I think that's all the questions I've got in the chat.
Okay. Are there any that you would like to ask over the phone lines? Now's your chance. Otherwise, Dr. Ellswick has posted his email and he's always available. If you should have questions or comments individually, feel free to reach out to him. Again, this will be posted on the Kentucky SOS website. I'll put the website address in the chat box. I will also send this out to the project leads. If you are not receiving the electronic Kentucky SOS newsletter every month, please let me know, and we want to get you on there. That's a great way also to keep up on all things Kentucky SOS. And thank you so much, Dr. Ellswick, today for this presentation. It was wonderful, and this is a great way to start our new year. We have a lot of exciting and lots of things happening with this program, and this is just a great example of a way that we can better treat our patients. And we're making great strides in Kentucky. It takes every one of us. So thank you so much for all you do. Again, you have some great accolades in the chat box. Thank you to all the attendees today, and be looking for future SOS events. And we will talk to you soon. Everybody have a great day. Goodbye.